Well, I wouldn't be standing here if it wasn't for Mike Katke. He was one of those friends that had a bigger vision of me than I had of myself. And he actually said to me, I'd like you to have the kind of influence in your field that Jeff Bland has had. Never told you that, Jeff. But I also wouldn't be standing here if not for my father. And today is the one-year anniversary of his death. He died peacefully in his sleep, just shy of his 90th birthday, and he was a cancer survivor. He was diagnosed in his 50s, and he had the best care from the best oncology disease experts. But he also had a health expert, and he was my first case study. He was free of cancer until his 89th year, in which time he had a small lesion in his spine. He ultimately died of cardiopulmonary disease and not of cancer. So what if every cancer patient had a health plan and a health expert and not just a disease-focused team? What if at the moment of diagnosis, instead of feeling like your hair just got caught on fire, that the oncologist said something like this: we've just diagnosed you with cancer, but we want to take our time and do some really precision medicine and figure out exactly what treatment is right for you, your genomics, your tumor cell line, the environment you live in, and how you got here. And while we take our time to do that, we're going to give you our health team. And they are going to teach you how to build and cause health and get through this so that at the end, our outcome is health. Now, there really isn't a health model in oncology at all. And if there is to be health as an outcome, there must be a plan for that health. So when you have a cancer diagnosis, your very first goal is to reduce tumor burden. You need to figure that out. But at the same time, we have to nourish patients who are going through challenging treatments. The need is huge. If you just look at this curve, you can see this is showing the number of cancer survivors. The diagnostic rate right now in the States is 1 in 2 men, 1 in 3 women. The age demographic in this room is at risk for cancer. Half the men, a third of the women, either have already been diagnosed or will be. In 2024, we're going to have 19 million cancer survivors in the United States alone, and over 40% of those will have been alive for over 10 years. Who's taking care of them? Who's teaching them how to stay healthy, not have a recurrence, recover from the long-term effects of their disease and their treatment? Now, if you did not specialize in oncology and didn't get some extra training in oncology and cancer care, you actually don't know very much about this patient population and what their needs are, particularly when they're done with treatment. So let's talk about what we can do in the functional medicine setting to place a health model inside of cancer care and become part of collaborative, integrative teams. First of all, I'd like to think about the phases of the cancer journey. This is important for the patient. It helps them understand what they need to focus on and kind of get out of the anxiety of what next, what if, because we really don't know what's going to happen next till we get through this phase. But also it's important for the clinician to know what the priorities are and what to focus upon. I want to bring your attention to a very large demographic of patients, and that is those patients living with cancer as a chronic illness. This is becoming a larger population of patients for whom no one is really attending to their health, and they may live decades after they are first diagnosed. And we hope that they do, and we hope that they do that with a good quality of life and a sense of agency and control over what is happening to them. So what can we do? We can transform outcomes and prognosis because we have a plan for their health. We can enhance the oncology treatments. We can also manage the short-term and long-term adverse effects, and this is one of the most important things that we do with our toolbox. And above all, we can provide a health model. I have been working with the top oncology groups in the Los Angeles area for the last 3 decades and proven this model, and they need us as a resource. So the first thing that we need to understand is that the tumor microenvironment is a milieu like the soil in a garden that is providing nutrients and signals to the cells that arise either as healthy cells or cancer cells. So we need to tend to that tumor microenvironment. That environment should send signals and create a physiology that is inhospitable to the proliferation and spread of cancer. And that's our goal. So let's talk about a couple of patients who might walk into your practice. I had a woman come into my practice who was planning to euthanize herself because she had such exquisitely painful peripheral neuropathy secondary to her successful breast cancer treatment. Today, if a woman is diagnosed with breast cancer, she should expect to live, but not with peripheral neuropathy that is debilitating. She came in about 8 years post-treatment. We took a look at her tumor microenvironment and her unique SNPs and looked at biomarkers that helped us understand what we needed to do to get her out of this dilemma. We found that she had very high levels of oxidative stress, and she had single nucleotide polymorphisms that made her very inefficient at quenching that stress. We found she had very high levels of inflammation, evidenced by elevated C-reactive protein, interleukin-6, ceruloplasmin, and ferritin, which are acute phase inflammatory markers. And we also found she had a reverse of she had more omega-6 to omega-3, so she really couldn't have healthy cell membranes and she couldn't manage inflammation very well. So we put a plan together for her which addressed all of these things. We taught her how to eat the rainbow, so she had a lot of phytochemicals and antioxidants in her diet. We taught her how to eat an anti-inflammatory diet. She was a smoker that didn't want to give up smoking, so we needed more oxidative stress quenching. But with this plan, with nutraceuticals, botanicals, and lifestyle guidance, and acupuncture, in 10 weeks, she didn't have a reduction in her neuropathy. She had no neuropathy. And that was 10 years ago. So all we had to do was provide the conditions for repair and the conditions for health and make sure that we weren't just chasing symptoms, but transforming function. So we have the toolbox to do that. Another patient, more poignant, more difficult, more challenging, who was referred to me by one of my esteemed and beloved colleagues sitting in this room, and we've shared this patient for a long time. This was a woman who was diagnosed with endometrial sarcoma. Sarcomas are very aggressive, fast-moving tumors of the soft tissue. They do not respond typically to chemotherapy and radiotherapy, which are still standard of care in oncology today. The primary therapy is surgical resection. So she had a complete total hysterectomy and debulking of her tumor mass in her pelvis. These patients typically recur quickly and aggressively, and this happened to her. 2 hotspots were found in her pelvis, but they were not resectable because they were all wrapped up in major blood vessels and nerves. So she understood the gravity of the situation, but being who she is, she decided to look outside the box. She's also one of those patients who's all in. Whatever hard things I ask her to do, she does them. So we wanted to look also at her factors so that we could put an effective plan together to take control of the progression of this disease. So the first thing you have to do is take a look at the tumor itself. You want to understand the characteristics of the tumor. There was a paper published in 2000 and updated in 2011 by Weinberg and Hanahan called The Hallmarks of Cancer. This describes the unique characteristics of tumor cells that allow them to survive, to proliferate, to metastasize. This describes the qualities of tumor cells that make them different from healthy, normal cells. So if we understand those factors, they lose their apoptotic switch. So an aberrant cell usually is identified and self-destructs. These cells keep reproducing their aberrations. These cells produce signals that allow them to build their own blood supplies so that tumors can grow and metastasize and travel and establish secondary sites. These cells will also produce lots of inflammatory cytokines. And so if you learn the 11 qualities of the hallmarks of cancer, you learn a piece of what we need to understand about tumor cells. Then we want to understand the landscape of cancer, the tumor microenvironment, and what are the factors there, and can we measure them, and can we then have an impact on the signaling that happens in that landscape in the same way we would do by changing the soil in a garden. So we look at things like glycemic control, oxidative stress, inflammatory factors, hormonal modulation, immune modulation, blood clotting. So let's see what we found in her. So we looked at a number of factors, and this is what we discovered. We discovered that she had elevated levels of transforming growth factor beta 1, which is a multifunctional cytokine, but it is also a significator of high levels of fibrosis. This is a picture of sticky fibrin, a mat of sticky fibrin protein with platelets underneath it, covering the surface of a tumor cell. This is a strategy of cancer cells. They create little raincoats over the surface of cancer cells so that the immune system can't see them or recognize them. And all our good therapies can also not find that membrane or the receptors on that membrane to exert their positive effects. And in essence, the tumor cell hides very effectively. This is also a hypercoagulation state. And so we discovered that she had elevated fibrinogen and D-dimer. And when we measure those, we can see how much coagulation is unfolding and breaking down, unfolding and breaking down, and see that this is an ongoing process. This is a typical milieu in the tumor microenvironment, very common. 40% of all cancer patients die of a thromboembolic event. We also found high levels of serum copper and ceruloplasmin and low levels of serum zinc. We also found high levels of vascular endothelial growth factor. These things tell us we're in a pro-angiogenic environment in which the tumor is able to build a blood supply. In conventional oncology, these are targets of drug therapies and radiotherapy, but we can affect these things with nutraceuticals and botanicals as well. And then we found she had elevated levels of hemoglobin A1C. Tumor cells have increased numbers of receptors for GLUT4, for insulin, for insulin-like growth factor. And so when you have a hyperinsulinemic, hyperglycemic environment, you have more growth signaling. So I focused part of my treatment plan on this transforming growth factor beta 1 for her because I found that it was a really good marker to show how much tumor burden she had over the many years that I treated her. And one of my favorite interventions is to use Salvia miltiorrhiza, red sage root, danshen. This, in modern Chinese medicine, is a well-researched botanical. It decreases fibrosis, coagulation. The salvinoleic acids and the tanchinones are active in turning on apoptosis, in cell cycle arrest, in inflammation control, in managing oxidative stress. So we find that phytochemicals are always multitaskers. I also include a wide variety of botanicals, especially adaptogenic herbs, because this is an inherently difficult and stressful process for the patient. Chinese herbs are rich in adaptogens. I want my patients to have stamina, endurance, and resilience as they go through their process. We also, of course, use very targeted nutraceuticals and botanicals, along with very specific dietary recommendations and functional foods. And this is in the context of epigenetic signaling. Can we turn off oncogenes? Can we turn on tumor suppressor genes? Can we change the expression of our inflammatory control at the nuclear level? I say to patients, it matters what you eat because your food is talking to your genes. All right, so I want my patients all to be outliers. I want them to defy the odds. I don't want them to be inside the bell curve. So what happened to this patient? This patient, because she's all in, does everything I ask her to do, and because we had a very targeted plan for her, she was under my care for about 18 months when I got a call from her oncologist. He's one of the top sarcoma experts in the world. His office is up the street from me. He said, can you come by? Came by, he said, you know, I fully expected her tumor to progress, and it actually shrank. She is now a candidate for surgery. Do you want to tell her or should I? I said, I am telling her. So I called her into my office and I explained this to her. I said, you know, instead of your disease progressing, we now have such small masses that we can remove them. And we both cried. And then she said, you know, I only have one daughter, and she is pregnant, and her due date is 3 weeks from now, and I would really like to be at the birth. Can I postpone this for a month? And I said, no, you cannot. This is your moment. This is your doorway. We have to do it now. Walk through it. So being who she is, she went and saw her surgeon, and I gave her a second referral because we had to find a surgeon who would say yes. And so she texted me and she said, I found out from the nurses that my surgeon is God and your surgeon is God Jr., so either one is good. And so then her surgeon took up the surgery, and I got a call. 3 days later, she's in surgery. That's who she is. So then I got a call from the surgeon after he was finished, and he said, you know, it was very successful surgery. I was able to remove those masses. And the pathologist told me there were no malignant cells in that tissue. So this is what is possible, right? This is what is possible, but you need a highly compliant patient. She did what I asked her to do, right? So I'm hard to say no to, so that's a tip. So she texted me when she got back to her room and got this news and said, did we just cure cancer? And of course, I don't get to say that. So I texted her back, and I said, one angel at a time. Now, that was several years ago. She's had a wonderful relationship with her granddaughter, and her last scan showed no evidence of disease. So this is what is possible. So why am I talking to you? Because we need frontline primary care clinicians who can teach patients how to have a health model for their cancer journey, whether they're at risk for occurrence, recurrence, whether they're experiencing adverse effects, whether they're recovering from their treatments, or whether they're living with cancer as a chronic illness. There is a shortage of oncologists that's going